Good evening, everybody. A very warm welcome to the day 2 of Atrophy Symposium. We had a very nice session yesterday covering inherited retinal diseases, atrophy related to it. And today the theme is on age-related atrophy. Uh, we have 3 sessions, enlightening sessions, and having 2 to 3 insightful talks. And that would be followed by a panel discussion after each of these in the end of the session. And I would request all of you to keep your microphones muted and only allow the designated speakers and panelists to use their microphones. And if you have any question, please feel free to type them in the chat box, and the session moderator will make sure that they are answered. So we'll start the first session. I'll request the moderator of the session, Dr. Rupak Roy. Dr. Rupak Roy is a senior vitreoretinal consultant at Shankanethralaya, Calcutta, and he leads the VR team at our SN Calcutta branch. Dr. Rupak, please.
Thank you, Dr. Rajiv Raman. Without much ado, we will start the presentation for today. The first talk of the day will be Geographic Atrophy Indian Perspective by Dr. Rajiv Raman. Dr. Rajiv Raman is a senior vitreoretinal surgeon at Shankanethralaya, Chennai. All over to you, Dr. Raman.
Good evening. I'll be sharing thoughts about geographic atrophy, the Indian perspective. I'll cover my talk in following headings, I'll be talking about, is geographic atrophy different in Asians? How common is it in India? How is the progression? Are the risk factors for geographic atrophy different in Indian population? How do they cope with the bilateral visual loss? Coming to, is it different in Asians? And this was a study which was done as a part of Asian Eye Epidemiology Consortium, where we tried looking at the prevalence and pattern of geographic atrophy across various countries in Asia. And from Shankanetrale, our team participated in this study. So if you can see, there are regional differences in Asia. We have countries where the prevalence of geographic atrophy is very low, like Japan and Thailand, it's nearly near to the zero. We have some countries where prevalence is intermediate and some where the prevalence is really high, especially India and Nepal. So these were the various studies from where the data was taken for doing this study. And you can see there are regional variation. The SN-RAM, Shankanetrale age-related maculopathy study, the Bhaktapur retina study from Nepal did show a higher prevalence. Overall, the prevalence in Asia seems to be about 1.57%. If you look at neovascular AMD, the prevalence of neovascular AMD seems to be high, nearly about 3 times, about 5.2% is the prevalence of neovascular AMD in Asia. So how it is different? In European countries, we have the ratio of geographic atrophy and wet AMD nearly 1:1, whereas in Asian countries, we have 1:3. So definitely in Asia, the prevalence of geographic atrophy seems to be lower than the white population. The ratio of geographic atrophy to neovascular AMD is also less. We found that men are more likely to have geographic atrophy as compared to women. And as I had shown that even within Asia, there are geographical differences with nearly almost no cases or very less cases in Japan, few in Taiwan, Hong Kong, Korea, and China, and higher number being in India and Nepal. Why we have less geographic atrophy, we really don't know the cause. However, probably some of the reason could be the larger amount of melanin pigmentation in our races, fewer pseudodrussins, we have longer axial length, and probably there may be some inherited genetic factors also playing a role as far as the AMD pathogenesis, and that may contribute to less geographic atrophy in Indian population. Are the risk factors different in Indian population? So as we saw that in India, the geographic atrophy is definitely more than other Asian countries. This was the prevalence and risk factors of AMD in Chennai, in South India, and we did find that there is no rural-urban difference. So unlike many other retinal diseases, which are mainly lifestyle, in AMD, there was no rural-urban difference which was seen. And as far as risk factors are concerned, one of the consistent risk factors was the increasing age. We found smokeless tobacco as a risk factor for geographic atrophy, and there were some protective factors, including diabetes. We also showed that people who are having smokeless tobacco, the risk of, they are 3 times more risk of developing geographic atrophy as compared to those who are not using smokeless tobacco. We also tried looking at visual impairment, and interestingly, in geographic atrophy, majority of them had mild visual impairment, meaning that probably they have fovea spared. This fovea is not yet involved. We also know from the Western data, this is the IRIS repository data, which shows that the progression, the 1-year people who have both eyes geographic atrophy is about 7%, and those who have one eye neovascular AMD, other eye have got a geographic atrophy, it's about 6%, and 2 years these rates are nearly doubled. So you can see that over a period of time, within 2 years, they can involve the center and cause visual impairment. How is the progression? We really don't have a prospective study in India regarding the progression of non-center involving to a center involving geographic atrophy, or data suggesting how many of them have dry AMD, the drusen's converting to geographic atrophy over a period of time. However, there was a good retrospective study done at LVP, which suggested that a good number of eyes, nearly 321 eyes they looked into, and they found the 5-year conversion rate to geographic atrophy was 3%, nearly 3%, equal to what we see with wet AMD also. Another entity we found how it is different. As I told, there's more male predominance. We have relatively thicker choroid than the white patients. And we also see geographic atrophy without drusen, with only pachychoroid. The GA progression in this population seems to be lower as compared to the white population. And the studies have also shown that the larger size of a geographic atrophy and the presence of reticular pseudodrusens were associated with greater progression rate. The average progression in Asian population seems to be about 1 millimeter per year. There's another distinct entity which has been described called as a pachychoroid GA, where we see geographic atrophy in a pachychoroid spectrum with the absence of drusen. They're usually younger, they're not symmetrical, or they're not bilateral. They have a smaller size of geographic atrophy. In Asians, 20% of the GA cases may have a pachychoroid geographic atrophy. So this has to be kept in mind whenever we are thinking of these therapies which are now coming up. How do they cope with bilateral visual loss? So this was one of the qualitative study which we had done, where we tried looking at what is the impact of living with a bilateral central vision loss with geographic atrophy. And what we found, these were in-depth interviews for about 20 patients with geographic atrophy. And we found that inability to recognize faces was the main reason of dependency and to others, and being socially disconnected. We tried looking at the challenges they have in day-to-day life, the challenges in lifestyle and socialization, the strategies they adopt to overcome these, and the psychosocial implications a person with geographic atrophy can have. So to conclude, geographic atrophy seems to be having a bit different epidemiological features in Asian, more so in Indian population. In Asia, India and Nepal seem to be having higher prevalence of geographic atrophy. Smokeless tobacco seems to be an important risk factor for geographic atrophy in our population. And definitely one should keep in mind that we have more of pachychoroid spectrum, and pachychoroid with geographic atrophy seems to be there in our population, and they are luckily having lower rates of progression as compared to age-related geographic atrophy. Thank you very much.
Thank you, Dr. Raman. We will go on to our next talk by Dr. Shobha Sivaprasad. She will be speaking on perspectives from clinical trials in geographic atrophy. Is geographic atrophy one disease? And Dr. Shobha is a senior retinal surgeon and professor of Retinal Clinic Research, Moorfields Eye Hospital, London. I welcome Dr. Shobha to start her talk.
Good evening, everybody. My topic is perspectives from clinical trials. Is geographic atrophy one disease? These are my disclosures. So we have had some success after at least 15 years of failed clinical trials in geographic atrophy. The FDA has very recently approved the complement anti-C3 and anti-C5 interventions for geographic atrophy. As all of you know, Syfovre, marketed by Apellis, targets C3, and Zimura Izervay by Iveric Bio and Astellas targets C5. The therapeutic indication from FDA is you can treat all eyes with geographic atrophy. So let's just review what we know about anti-C5 interventions. This is the first anti-C5 intervention that has worked to the extent that we have received FDA approval. Previously, we have had two other anti-C5 interventions, i.e. eculizumab, which was given intravenously. It was an anti-C5 humanized monoclonal antibody, and then LFG-316 from Novartis, which was another monoclonal antibody against anti-C5. So a question arose, why is that other anti-C5s have failed while avancincaptad pegol, Zimura, or Izervay, which is a pegylated RNA aptamer, has worked. So some questions have been raised whether it is due to the pegylation that this drug is working. However, experts in pharmacology have informed us that it is not the pegylation, and it is really showing a decreased growth rate in geographic atrophy. So this is the history of anti-C5 interventions. Now let's progress to anti-C3 interventions. Again, we have very similar outcomes. The POD4 was the first intravitreal C3 inhibition. It failed. And then, of course, pegcetacoplan from Apellis, now another aptamer, has given intravitreally, has had FDA approval. Very recently, NGM 621, another monoclonal antibody to anti-C3, failed its primary endpoint. It was also of intravitreal delivery. Again, questioning why some anti-C5s and anti-C3s work while others don't. So one question we need to ask is it something to do with the trial design? All these trials have had very similar trial designs, so that can't be the sole answer. The lesion area was 2.5 to 17.5 millimeters square in most of the trials. And if GA was a multifocal, at least one focal lesion should have been 1.25 millimeters square or more. And the presence of hyperautofluorescent rim around the geographic atrophy was a must in most of the trials, assuming that these lesions suggest active lesions. The primary endpoint was also very similar among these trials, reduction in GA enlargement rate on fundus autofluorescence relative to sham. It is an FDA-approved primary endpoint, and all these studies used the same. One must remember this graph very vividly because the geographic atrophy enlargement rate is very variable between individuals. And you can see here that although the average growth rate is supposed to be 1.5 to 2 millimeters square per year, you see that very few people have that growth rate in this huge proportion of patients that have been recruited to this trial. This is by a cohort recruited by Sannes et al. So this shows the variability, and this may explain differences in results in the trials. This is a meta-analysis done for all the natural history studies that have been looked at GA enlargement rate in millimeters square per year. And you can see that although the average still turns out to be between 1.5 and 2 millimeters square, you can see a whole cohort of patients either having less growth rate than the average or higher growth rate than the average. So clearly it depends on the proportion of patients with fast progressors or proportion of patients with slow progressors in the trial that determines the result. At least it's a major contributory factor. Now let's look at the results. Pegcetacoplan is the 24 months results of the Derby and Oak study, definitely showed that monthly pegcetacoplan or every other month pegcetacoplan resulted in a reduction in growth rate over 2 years, and the separation is increasing as time passes, giving suggesting a cumulative effect. And the same result was seen with the GATHER1 study for avancincaptad pegol or the Iveric Bio intervention. Again, this time, this is the 2 milligram versus sham group, again showing about 28% risk growth rate reduction compared to placebo. So what does all this mean? When we look at the untransformed enlargement rate, The control group increased by 1.88 millimeter square to 2.11 millimeter square. So that's within the average of 2 millimeters square. With monthly pegcetacoplan, this area reduced or was lower by 0.38 millimeter square, and every other month it was 0.29 millimeter square. So what does it mean in terms of growth rate, square root of growth rate? It's actually 0.09 millimeter lower growth rate compared to sham in case of monthly pegcetacoplan, or in every other month it was 0.07 millimeter lower. So clearly, yes, it definitely reduced the enlargement rates, but the reduction rate was very small. Now let's look at the lesion size once again. These both drugs had a lesion size inclusion criteria of 2.5 to 17.5 millimeters square. And you see that one anti-C3, which is an aptamer, pegcetacoplan, approved by FDA, reverse NGM 621 anti-C3 monoclonal antibody failed. Same lesion sizes. Now, if you look at Catalina trial where NGM 621 complement C3 inhibition was done, you see that their growth rate was very similar between anti-C3 and sham. So this is why this trial failed.
Yeah, there is an issue with the sound.
I think that is this slide. Dr. Shobha, can you just continue?
Yeah, so I will explain the slide. So what we saw was a failed primary outcome trial. If you look at the gene therapy trials, the gyroscope trial that
Yeah, you can start now.
Yeah, so if you look at the primary outcome trial, you see that the trial failed. But in this post hoc analysis, what they did was they looked at what happens to the lesion size growth rate when the largest lesions were removed. So the lesion sizes were between 4.17 and 9.64. And suddenly you see the same pattern as you see with Apellis. So this just demonstrates to us that lesion sizes matter, and that the lower end and the upper end were particularly slow at growing, and therefore the results were, it failed. Let's carry on with my recorded slide. If you look at the gene therapy trials, the gyroscope trial, that is GT005 gene therapy, had lesion sizes even of wider spectrum from 1.25 to 17.5. And that trial just released their results that they have failed, or they have discontinued those trials. A new trial has just started, the Parasol, which is for CD59 gene therapy. Here they have made their lesion sizes much smaller, range between 2.5 and 12.5. So it is difficult to compare between trials, even with lesion sizes. So we have to be very cautious when we compare trials. I think the most important feature we all need to know is to identify the fast progressors. So far, we only know that a hyperautofluorescent rim around a geographic atrophy is a sign of activity or growth, and disc size or disc areas of more than 4, equal to or more than 4 disc areas are likely the ones that will grow the fastest. But it still doesn't pick up specific cases. If a patient is sitting in front of you in clinic, you wouldn't know from all this data which eye should be treated or not based on their progression rate. The same variations exist for extrafoveal lesions as well. So the distance to the fovea is the key determinant of visual prognosis. Most of the GA, which are extrafoveal in location, grows outwards. The fastest progression is determined of GA within the range of 0.5 to 1.6 millimeter from the fovea. So we must remember that this again tells us what we have to look after is we have to review our patients and make notes to see which of these patients are the fastest or grows rapidly, and then discuss this treatment option with them. There are other risk factors for progression on imaging. As you can see, the high-risk cases are multifocal, large-sized, extrafoveal, with a rim of hyperautofluorescence. If the fellow eye has had GA, it's very likely that the eye you're going to treat has got a high risk of progression. Eyes with subretinal drusenite deposits, with thin choroid, with choriocapillary deficits, and signs of hyperrefractive foci are all high risk of progression. So these give us a general idea as to who to choose to treat. However, it must be well informed. Patients must be well informed that the perceived growth rate reduction is small, and they should be very compliant with their treatment. This is a patient with subretinal drusenite deposits. These patients have very poor low luminance visual acuity as well as prolonged rod intercept time. They also have a very thin choroid, and these type of eyes, we do not even know whether these eyes are reversible at all, or whether the rate of progression with an intervention can be slowed. Jordi Monet also thought we could actually phenotype GAs into 3 types, one with a lot of drusen, and the other end is the ones with SDD or subretinal drusenite deposits. And then you have a big clump of other group of patients which form the intermediate or the middle group. Is this important? Yes, the lead trial showed us that patients with intermediate AMD, when they were treated with subthreshold nanosecond laser, on the whole, if you looked at that study, it showed that there was no treatment benefit. However, when you look at those with the drusen eye, that is the first type of phenotype that Jordi Monet described, except that this is for intermediate AMD, that group seemed to respond better, and the groups with the subretinal drusenite deposit did not benefit from the treatment. So these type of morphological characteristics are also important when you decide treatment. So in conclusion, GA trials have definitely given us that way forward. There are 2 trials now, anti-C3 and anti-C5 pegylated interventions that are showing us that there is a reduction in GA growth rate with these, and they are FDA approved. So as a minimum, when you decide which patients to be treated with this, make sure that they are monitored to assess whether that patient at an individual level has got a documented increase in growth rate more than 2 millimeters squared per year, and also look at their lesion sizes and their probability of non-foveal location. And presence of SDD is a poor prognostic indicator, and you may wish to see whether these patients are really worth the treatment or whether this group has already missed the boat. Further studies are required to understand progression rate, and that may be the way forward when we get these interventions in our hands. Thank you very much.
Thank you, Dr. Shobha, for a wonderful talk. We will move on to our panel discussion. For that, I invite Dr. Dhanashree Ratra, who is a senior vitreoretina consultant at Shankarnetralaya, Chennai. We have Dr. Raja Narayanan, who is the director of Anand Bajaj Retina Institute at LV Prasad Institute, Hyderabad. And we have Dr. Janani Srinivasan, who is a vitreoretina consultant at Shankarnetralaya, Chennai. And of course, Dr. Shobha Prasad will be one of our panelists for this discussion. So if I can start with you, Dr. Dhanashree. Now, with the treatment of geographic atrophy coming into horizon, when you see a patient in your OPD, has your outlook really changed in terms of how do you image a patient routinely? Because previously mostly would have done OCT, but now has your imaging practice changed when you see a patient with GA?
Thank you, Rupak, and thank you, Rajiv and Dr. Shobha, for the wonderful talks. We really enjoyed them. So what you have asked, Rupak, is a very pertinent question, and I am sure with time the practice will have to change. But as you know, so far those treatments have not been introduced in India, and we are not actually clinically using those treatments so far. So as of today, if you ask me, there is no change in the way we investigate or we, follow up the patients. But as we go forward, probably we may have to, take into consideration the higher investigations or the better modalities which might be required, such as autofluorescence, etc. Thank you.
Yeah, I'll ask the same question to Dr. Shobha also. I mean, has your clinical practice changed, or are you in the process of changing it, anticipating more and more treatment of geographical atrophy in your practice?
Yeah, so thank you, Rupak. So we have not got the drug either as yet. However, we still do autofluorescence on our geographic atrophy patients, and we intend to do that and monitor some of our patients, at least, who are still in our system, to look for the growth rate of these patients, because we believe by the time the drug comes, we will be able to analyze which patients are fast progressors. Regarding OCT, of course, that's our routine device that we use, and we have the CAM group classification of IRORA, CRORA, etc. But they were not used in the trials, and therefore, to look for treatment benefit, we will then have to come up with our own reduction criteria. And I don't think any of us are proficient enough in assessing growth rate on an OCT. So I would still continue on autofluorescence for assessing growth rate.
Yeah, thanks, Dr. Shobha. I have a question for Dr. Janani. Now, a lot of these platforms, imaging platforms, do not have autofluorescence and OCT in the same system, but most of these platforms will have the infrared imaging. So, what will be your? Have you looked into how good an infrared imaging is to document the lesion size? Because infrared, we all know, gives us good idea about RP changes and all those areas of in CSR particularly.
Yes, sir. Because recently, when I first see a patient, after so many studies on autofluorescence and infrared reflectance imaging, I have started to see the extent being more readily picked up in autofluorescence and IR imaging, especially subretinal retinoid deposits. Many studies have shown color fundus photography or in the fundus examination is a little bit inferior compared to those imaging. At least it's a good idea to have a baseline, especially spectralis, which comes with a multicolor imaging. I'm sure you have more expertise than me. So that is a good tool to have an idea about the extent of subretinal retinoid deposits which are associated with a high risk of progression and atrophy. I do have a question. So the recent drugs which have been developed for geographic atrophy, can they be extrapolated for patients who have developed atrophy following treatment of wet AMD, especially type 3? So what do we have for these patients, whether or the other array of patients who have been treated with wet AMD? So that was a question I wanted to ask Shubham.
So the clinical trials definitely did not give us that, they were exclusion criteria. So at present, if we get the drug in the UK, it will not be used for that macular atrophy. I believe these industry partners are starting clinical trials on that particular area. Again, it's very difficult to judge the growth rate in those lesions with the presence of choroidal neovascularization or RAP. So it will be challenging. At present, it's not an indication.
Thank you, Dr. Shobha. Dr. Raja, are you there? Yeah, so I think he's not there. Dr. Dhanashri, do you feel there has been, like Dr. Rajiv Raman talked about pachychoroid geographical atrophy, which is an interesting concept where you have a thick choroid, but you really don't see drusen. Have you really encountered this kind of patients in your practice?
Yeah, in fact, I wanted to ask that question to Rajiv because I wanted to ask him whether is there any correlation between the choroidal thickness and geographic atrophy, because we know that AMD has got thinner choroids, and similarly high myopia also has thinner choroids. But we know the high myopia does not have that much incidence of geographic atrophy. And but he spoke about this pachychoroid which has developed geographic atrophy. So it's a little bit contradictory. So in fact, I would like Rajiv to answer this question, that what he thinks is the correlation between the choroidal thickness or the choroidal vascularity and the incidence of geographic atrophy.
As you rightly said, that the AMD is usually associated with thinner choroid. So you have lepto choroid type of thing rather than pachychoroid. However, if this is a new entity which has been described, that sometimes a patient with a pachychoroid may have patches of atrophy, and these are again, they don't have drusen, they are unilateral. This is something I read new, and I already asked my fellow to start looking at our pachychoroid. How many of them have this? And interestingly, the 20% seems to be same. Like we know that sometimes CNVMs, wet AMD 20% may turn out to be pachychoroid or PCV. Likewise, in PCV, 20% maybe the GA would be not age related, but pachychoroid GA. This is something we need to explore more. Dr. Shobha, do you have any experience of pachychoroid with geographic atrophy lesions?
You're right, Rajiv. There are very few patients with atrophy in these eyes because it looks like there is a choroid is of course protective. The issue here is we do not have imaging on choriocapillaries, right? So we say the ischemia, pachychoroid neovasculopathy is due to ischemia of the choriocapillaries. So we don't know whether the disappearance of the choriocapillaries will then lead on to atrophy. That is one area I think we need better imaging to understand that better. But yes, it is definitely lower prevalence in pachychoroid.
So there was one in this connection. There was one article published in Eye Journal by Dr. Karkes and group, which actually compared the leptochoroid between reticular pseudodrusen and that of high myopia, and the incidence of atrophy. And they suggested that although there is a thinner choroid in high myopia, there is a less damage to the vascularity of the choroid. So you may have they actually looked at the choroidal vascularity index, and they said that there is a stromal atrophy but not vascular atrophy, and they in fact said that acts as a protective factor for high myopia and prevents formation of AMD.
Yeah, that is a good point. But then again, we have to understand this pachychoroid is a very broad term, and there is a lot of semantics involved. Which is a pachychoroid? More than 300, more than 330? Whether does it have a pachy vessel? How do you really identify a pachy vessel in a basic clinical practice? And also, do you really do ICG to look for hyperpermeability? So a lot of factors are there. As Dr. Rajiv said, we really look into this. Thank you for this wonderful discussion. I will now invite my colleague, Dr. Arko Prabha Pradhan, to moderate the next session. Dr. Arko, please.
Thank you, sir.
Dr. Arka?
Yeah. Good evening, everyone. Thank you, Rupak sir, for a kind introduction. So now I will call upon Dr. Srinivas Sata, the Director and Professor of Rohini Eye Institute and at University of California. So he will enlighten us on imaging atrophy in AMD. So over to you, sir.
I want to thank Rajiv Raman and the other organizers for the opportunity to be able to participate in this great meeting. I was tasked with discussing how we image atrophy in the context of AMD. And I just want to, by way of disclosure, I do work with, in particular, what's relevant here with a number of imaging companies, and many of them have products that are helpful in assessing GA. So let me start with sort of the overarching question here is what diagnostic techniques are actually helpful in our assessment of atrophy in AMD? And actually, several years ago, as part of the CAM initiative, we actually reviewed a number of different imaging modalities to see how they could be relevant, particularly for use in clinical trials, but also for clinical practice. And this is a table from that, which is really too busy to read, but really to highlight that we went through different imaging modalities and really tried to extract what we felt were their advantages and disadvantages. So I want to talk briefly about these major imaging technologies and what we perceive are their potential relevance in assessing patients with atrophy. So flash color fundus photography really has been the gold standard technique for diagnosis of atrophy for many decades. There's a definition of atrophy by color imaging where you look for the presence of sharply demarcated borders and depigmentation, as well as increased visibility of the choroidal vessels. That helps us in identifying atrophy. The challenge, though, with color photography is that to do this reliably, you really need to have good stereopsis. You can imagine here, we all appreciate this patient has atrophy, but can you really tell exactly where the borders are? It's a challenge. There's another example here where the contrast may not be sufficient. And this is obviously getting really high quality stereo photographs, not something that's always practical in the context of large clinical trials and maybe even in clinical practice. So how can we improve the contrast for identifying atrophy with color imaging? Well, that's where there's been a number of important steps forward in recent years with the broad availability of confocal imaging technology, and also talk about multicolor imaging, which generally occurs on confocal platforms. And so just if you use, for example, this is actually an image from the iCare or Center View Aiden camera. It's not a SLO device. It uses a LED light source, white light, but it passes it through a slit aperture. It's not fully this image on the right. Excuse me. It's not a pinhole aperture, but it provides a degree of confocality, and you can see that there perhaps is increased sharpness of visualizing vessels. But I want to highlight that the improvement, I think, really appears when you're looking at comparing, for example, assessment of this patient with drusen and atrophy. Again, compare the confocal color image compared to standard image, and you can see much better visualization of the atrophy. Here's other comparisons where, again, you can see confocal color imaging seems to help. And in fact, we published this analysis where we compared the GA assessment using fundus autofluorescence, which I'll talk about in a moment, compared to confocal color, and we found very similar performance, demonstrating that confocality, adding that to color imaging, actually improves our ability to assess atrophy in our patients with AMD. Now, of course, once you use confocal strategies, you can also take advantage of scanning laser technology. And when you're using SLO imaging, which you can reconstruct a color image by using red, green, and blue lasers, and that's something that, for example, the Nidec Morante device uses. Here's an example of really, I think, very beautiful imaging of atrophy using this technology. But once you actually have SLO imaging using multiple lasers, you're no longer limited to using red, green, and blue. You can do, for example, what Heidelberg does, substitute the red with infrared. Infrared light obviously penetrates deeper, so may be better for visualizing the RPE and the photoreceptors. It does create this more funny looking kind of color, but it may be beneficial for deeper structures. And again, here's another example of a case with geographic atrophy where you can again see very nicely delineated on the multicolor images. And so this is kind of a comparison showing a standard flash color image, a confocal white light image, and a confocal multicolor image. And I think you can see the confocal techniques really seem to help. Well, what about other approaches to assessing atrophy? I want to talk next about fundus autofluorescence and then OCT, because those are probably the dominant technology these days. So what about fundus autofluorescence for macular atrophy assessment? Again, this is that case I highlighted earlier where it may be difficult to appreciate the borders of the atrophy on the standard flash color imaging. But again, we can see with autofluorescence, atrophy is readily identified with well-demarcated borders with these areas of decreased autofluorescence. In fact, because of this high contrast is one of the reasons why enlargement of atrophy on fundus autofluorescence, that's been the key outcome measure in clinical trials. Now, when you use blue light autofluorescence, it's not a panacea. There are some limitations. It certainly is uncomfortable for patients. If you ever had blue light autofluorescence imaging done on yourself, it's not very pleasant. And there's been some concern that perhaps repeated intense blue light exposure may actually have toxicity. Obviously it's safe from an ANSI standard standpoint, but that's in normal individuals. Patients with atrophic macular disease, maybe it's not okay. Don't know for sure, but that's a concern. And that's where there's been a thought about using alternate wavelengths. This is a nice paper from Max Fau and the group in Bonn, where they compared green light autofluorescence versus blue light autofluorescence on the spectralis, and they showed that you can get essentially equivalent measurements. In fact, green light autofluorescence, because it's not impacted by macular pigment, it's easier for the foveal assessment of whether the atrophy is foveal involved, and they found it to do very well. Now, one of the challenges, though, of doing green light fundus autofluorescence is that most people don't have the green light, for example, on their spectralis. And also, I would argue that posterior pole FAF imaging in general is not always broadly available in clinical practice, particularly when you're talking about optometric practices. And that's where, certainly in the United States, many of these GA patients reside there. And of course, you can have very large GA lesions that extend beyond the central 30 degrees. So this is where there may be a potential value of ultra-wide field imaging. We had published a lot of papers in the early days of ultra-wide field imaging on the Optos platform using, again, a green fundus autofluorescence approach. And this is just to compare now, now that Optos has introduced true color with the red, green, and blue color, as well as both blue and green autofluorescence on the platform. We have many options, but I still very much like green autofluorescence. Just an example of another case with GA highlighting this. But there are some potential concerns, though, right? So clearly, I've shown some examples where you can see the atrophy well in ultra-wide field fundus autofluorescence imaging. But if you're going to actually use this to identify and then monitor GA, well, what about the repeatability? I mean, this really hasn't been studied before because, you're talking about essentially zooming in to a small field. So that means you're going to lose some resolution. And so the question is that resolution that you still get, is that good enough? And also the Optos images are on average, unlike what you get with the spectralis. So the question is, they're going to be noisy, a little bit more noisy as a result. And so are they sufficiently clear? And so we studied this in this, this was a study we did in collaboration with Nick London. We recruit patients at UCLA and also at UC SD with Nick London. And this is just a comparison of a case where you can compare the Optos versus the spectralis, Optos green versus spectralis blue. And we actually did detailed grading. We even used the region finder for the HIAX. I'm not showing that here, but we also did, just to make the thing similar, we did planimetric grading where the graders, in a mass fashion, or at least they were independent, multiple graders, they tried to draw the borders of atrophy. In fact, we had 5 graders, and we showed that actually the devices can yield relatively similar measurements. And actually, most importantly, when we looked at the repeatability of 5 different graders, we found excellent repeatability using the Optos platform, at least as good as the spectralis, which I think is very promising. Okay, so what about OCT? OCT, I think, is probably the dominant technology we use in our clinical practice. It's even more comfortable than on fundus autofluorescence, of course. And of course, atrophy is readily seen. You can see these areas of hypertransmission. And so if you get the so-called OCT fundus image or projection image, you will see the atrophy appearing as hyperreflective areas on that slab, especially if you do a dedicated choroidal slab because of all this hypertransmission. And we have shown, this is a paper looking at data from the Mahalo study of lampalizumab, which obviously didn't work, but the FAF and OCT measures, you see the FAF area plotted versus GA area of the OCT, you can see that they're highly correlated. I want to highlight, though, that although they're highly correlated, it doesn't necessarily mean they're measuring the same thing. And in fact, we have evidence if you do a pixel by pixel comparison, they are slightly different. One of the challenges, though, of using this kind of assessment OCT, looking at these areas of hypertransmission, if you look at just the en-face image alone, as many of the devices currently do, the question is, are all of these areas of hypertransmission evidence of atrophy? Maybe some of them are incipient atrophy or nascent atrophy. And the question then becomes, what's the threshold? And that's, of course, we didn't have a consensus on this, and that's why we actually started the CAMP program, and we came up with these definitions. We defined GA more broadly on OCT as complete RP and outer retinal atrophy, or CRORA, which is defined as having this hypertransmission. But just to make sure it was repeatable, the reading centers in the CAM group, they suggested using a minimum size of 250 microns. And again, it couldn't just be hypertransmission with some overlying RPE depigmentation, for example. You actually had to have RPE attenuation or loss, like in this example. You can see where the RPE band kind of jumps down. And so that also had to be at least 250 microns. And then you had to have some evidence of overlying photoreceptor degeneration. And as long as you had had those three components, then we could call it CRORA. And we demonstrated, and many reading centers have demonstrated this now, that even with relatively small lesions, we could achieve a high level of integrator repeatability using these CAM criteria. So we look at not only the en-face image, but then we look at the overlying B scans to confirm that the criteria for CRO is met. Now, the good news is that in the future, I think we're not really going to need reading centers for this process. We and others have developed, I think, very nice deep learning algorithms which can really perfectly segment these GA lesions. They really do a beautiful job. We think they do at least as well as humans. This is just to show that we could do this actually not only in GA, but also in Stargardt. I know that's going to be a discussion for the next day, but just to highlight this could be done with a high level of repeatability, and then just to show that we're not the only group. Other groups have done this using the en-face image. I think, in my opinion, while the hypertransmission is excellent, you still have to confirm that the overlying RPE and photoreceptors are impacted. Make sure it's not depigmentation. So I think another step is still required. And of course, really the desire for the future is to actually take all this information, and especially if you train your deep learning model with longitudinal information, that you can actually take the baseline image and start to predict the growth of atrophy. This is a recent paper we published in collaboration with a number of authors based on these huge data sets from the failed lampalizumab chroma and spectrum trials, as well as the natural history Proxima study that was able to demonstrate good model performance in making this kind of prediction. So lastly, I want to end with this concept, though, that even though we really focus on identifying atrophy based on the features I mentioned for the different modalities, and we also measure the atrophy to monitor the efficacy for therapies, but I just want to highlight that the current strategy for measurement may not be sufficient for some types of therapeutics. And so take this example for example, of stem cell-based therapeutics. And stem cell-based therapeutics, they're delivered to a certain area, and they may actually exert a regional effect. Maybe they only work in the area of the atrophy that's closest to the cells. And so we got very interested in looking at directional kinetics-based analysis, where we looked at the growth rate in different meridians in different directions. We published on that, and we actually then demonstrated, this was a paper published in Ophthalmology Retina a couple of years ago, that there is a phase 1 trial of a candidate stem cell therapy for GA, and the overall trial failed because they didn't see a big difference in terms of the GA growth rate. But what we demonstrated was, if you looked at the directional radial GA growth rate, we actually found that the growth towards, and you can see this heat map showing the growth towards the atrophy seemed to be quite a bit slower than growth away from the, growth towards the stem cells seemed to be much slower compared to growth away from where the stem cells are positioned. So this was an effect that was missed. This was actually statistically significant. And again, this sort of company went belly up. The trial was stopped because they didn't see an effect, but maybe we were studying it the wrong way. So to summarize, progression of area of geographic atrophy is the most commonly used endpoint for monitoring efficacy in current dry AMD trials. With the availability of therapeutics for GA, there's an increasing need to not only identify, but reliably monitor atrophy. I talked about, how with flash color was kind of the historical gold standard. The current standard in clinical trials is blue fundus autofluorescence, but I think in clinical practice, I think we have other options that I tried to highlight, which may make it a bit easier for our patients. Thanks very much for your attention to this, and thank you very much for the opportunity to participate in this symposium.
Yeah, thank you, sir, for the wonderful talk. So now, next I will call upon Dr. Gavin Tan. He is a Vice Chair and Director and Senior Consultant of Singapore National Eye Institute. So today he will enrich us on biomarker of geographical atrophy. So over to you, sir.
Good evening. I thank the organizers for inviting me to give a talk on biomarkers for geographic atrophy. These are my financial disclosures. A bit of background on geographic atrophy in Asia. We know the prevalence of this study demonstrated 1.5 per 1,000 persons above the age of 40. That increases as expected of age, about 2.9 per 1,000 over 70, and that's much lower prevalence that has been reported in whites. And comparing between parts of Asia, it is higher in South Asians compared with East Asians. In this study, looking at geographic atrophy phenotypes in subjects of different ethnicities, it demonstrated that GA area was smaller in Asians compared to non-Asians. Asians had fewer GA foci and had a slower rate of GA progression. The factors associated with GA lesion growth were, most importantly, ethnicity, junctional zone FAF pattern, baseline GA area, and the number of GA foci. However, eyes with baseline GA lesion above 5 mm squared showed the highest rate of growth, and in this category, there was no difference in ethnicity that was significant. The availability of new treatments for geographic atrophy has highlighted the need to identify who is at most at risk. The data from the IBAZE study, Demigata 1 and 2, demonstrated that an individual drug reduced the rate of GA lesion growth by about 17.3%. And for the Sephorvia study, which inhibits all three complement pathways, they demonstrated a reduction of GA growth about 21%, with a greatest benefit of 36% reduction occurring in the Derby study in the monthly group, and that happened at about 18 to 24 months. Therefore, we need better biomarkers for AMD, and these biomarkers must improve our ability to assess which patients are at greatest risk of progressing, and these will be key to ensuring individualized management and timely intervention before substantial and irreversible structural damage has occurred. Let's look at the most classic biomarker for AMD progression, the presence of drusen itself. In the ARES trial, they identified maximum drusen size and the presence or absence of pigmentary abnormalities as being important biomarkers for progression to late AMD. As you can see, the lowest risk with no drusen and no pigmentary abnormalities had a less than 1% risk of progression to late AMD, whereas in eyes with large drusen in both eyes, as well as pigmentary abnormalities in both eyes, the risk increased to up to 47%. Other baseline features of atrophic lesions predictive of GA progression have been identified on color fundus photography and fundus autofluorescence. These include baseline GA lesion size, having multifocal lesions, and an extrafoveal location of the lesion. There were also noted to be baseline unifocal lesions progressing to multifocal or other patterns had a greater risk of GA progression than eyes with a stable configuration. Patterns of atrophy on fundus autofluorescence have also been identified to be important. In this paper from 2014 by Holtz, he described various patterns of age-related macular degeneration on FAF. And it was noted that the banded and trickling pattern of atrophy had the highest risk of progression.
Kevin, can you tell about this slide, because the audio is not there in this slide? You're online.
Oh, apologies.
Yeah,
I don't know what happened to the
slide.
audio. So I think as I think Bas mentioned earlier, OCT is becoming very much more important in the evaluation of the risk of progression of geographic atrophy. And I think a few terms that are important to understand. I think he highlighted it a little bit earlier, but the terms that we use commonly now is CIRORA and IRORA. CIRORA refers to complete RP and outer retinal atrophy. And these are the criteria that was just repeating what was mentioned. You need both a choroidal hypertransmission as well as an area of disrupted or attenuated RP of at least 250 microns or more, with an overlying photoreceptor degeneration or absence and an absence of an RP tear. Next slide. And Aurora is a kind of has similar definitions as Aurora, but without the size requirement. So if you have lesions that don't meet the Aurora definition, then it's considered to be Aurora.
Evidence of
Okay. Yeah. I think you can go to
receptor degeneration without RP or tear.
I think you can play if the audio is there. Oh, so these are a couple of cases. I don't know what happened. Audio that demonstrates the progression from just drusen change with hyperreflective lesion, developing Aurora and eventually Cirrora and geographic atrophy. Okay, let's move to the next slide.
Or Cirrora. The most well-described include the increased heterogeneity of the internal structure of a drusenoid lesion. This is often also described as a hyporeflective core of a drusen or a calcific drusen.
And the other high risk factor in OCT would be the presence of intraretinal hyperreflective foci, which represents RPE or pigment migration. Other OCT risk factors for progression include subretinal drusenoid deposits, or also known as reticular pseudodrusen, and these are often commonly associated with a thin choroid. So what data demonstrates these OCT risk factors for progression? In the fellow eyes of the Harbour study, it was demonstrated that having hyperreflective foci had the highest hazard ratio of progression to late AMD of 5 times. Having the hyperreflective core within the drusen or calcific drusens had an increased hazard ratio of 2.4, and the presence of subretinal drusenoid deposits gave you a double hazard ratio. The last significant factor was also a drusenoid volume of 0.03 millimeters cubed or more. This separate study, which also described the OCT risk factors for development of atrophy in eyes in intermediate AMD, confirmed the importance of hyperreflective foci and the hyperreflective drusen core, but it also noted that having sclerosis in the fellow eye was an important risk factor, as well as having a thin double layer sign, which represents basal laminar deposits, and the presence of subretinal drusenoid deposits.
So this separate paper is actually from Vasa's group, and it did try to dissect the differences between the drusen characteristics when you talk about risk. And they found that it was not just the overall area, it was the height that was the most important risk factor. The hypothesis was that the apex of the drusen was further away from choroidal blood supply, and OCT risk factors often also occurred at the apex of these drusen. And that became a more important biomarker than just the width or overall size of drusen alone.
This natural history study examined the changes of the RPE on OCT in dry age-related macular degeneration. There were 81 eyes that developed iRORA lesions in the study, and of those, 93% converted to CRORA within 24 months. They concluded that iRORA was the most important risk factor for progression to CRORA. They also found that hyperreflective foci was an important risk factor, as well as extrafoveal location of iRORA progressing faster than those with a foveal location. So is the progression of iRORA to CRORA an important biomarker? This data from the pegcetacoplan phase 2 geographic atrophy study, the Philly study, found that when looking at conversion of iRORA to CRORA, treatment with the drug reduced the risk of conversion by 60% compared to sham. This was similarly noted in the GATHER1 study when looking at conversion of iRORA to CRORA instead of a color fundus or FAF endpoint. They found that the risk of conversion was reduced from 30% in sham to 15% in the intervention group. Therefore, OCT biomarkers may be a better surrogate than FAF endpoints for the prevention of geographic atrophy progression. And it appears the presence of iRORA is the best risk factor for conversion to CRORA. In the Choroidal study, there was a 30% conversion at 12 months, and the GATHER1 study had similarly a 30% conversion at 12 months, whereas the Philly study had a 60% conversion at 12 months as a natural history. Another OCT finding that has shown to be an important biomarker for progression of geographic atrophy is the presence of nascent GA. This is defined as the subsistence of the internuclear layer and the outer plexiform layer, or the presence of a hyperporeflective wedge-shaped band in the outer retina. Therefore, an eye can either have iRORA alone, nascent geographic atrophy alone, or presence of both iRORA and nascent geographic atrophy. In this study, 280 eyes with bilateral large drusen without nascent GA or late AMD were observed. The probability of developing iRORA in these eyes was 26% at 12 months and 45% at 36 months, whereas the probability of developing nascent geographic atrophy was 6% at 12 months and 21% at 36 months. Importantly, In eyes with iRORA alone, the probability of conversion to geographic atrophy was 2% at 18 months and 9% at 30 months. In eyes with nascent geographic atrophy, the risk was much increased, with 22% developing GA in 18 months and 56% developing GA at 36 months. Lastly, as a further understanding of the features of hypertransmission on OCT, this study demonstrated that persistent hypertransmission defects detected on on-fast web source OCT was able to independently predict the formation of geographic atrophy. They found that eyes with persistent hypertransmission defects at baseline or follow-up had a cumulative proportion of developing GA at 62%. The prior biomarkers have all been well-defined, characterized features which have been identified by human or human graders and used to look at a longitudinal risk of developing or progressing for geographic atrophy. We increasingly know that the human's ability to identify features on images are limited, and the advent of artificial intelligence will improve our ability to make disease prediction or prognostication from imaging at a much better accuracy compared to human-defined qualitative biomarkers alone. So we do expect that there will be a future of AI-based biomarkers. These may be automated quantification of existing biomarkers that have been defined previously, like the hyperreflective foci or presence of cirrhora or iRORA, or they may be AI biomarkers which are identified by the artificial intelligence with unsupervised or loosely supervised learning, looking at baseline images with the information of the final prospective outcome in these patients. There have been multiple studies looking at AI-based biomarkers. However, there are much fewer where there has been external validation done. In this review paper, they identified 4 of these studies where the internal results demonstrated an AUC between 0.7 to 0.97, which is extremely good. And there have been obviously a drop in the AUC when looking at external validation results, but surprisingly, they're still above 0.8 AUC, and that is very, very encouraging for the future use of AI-based biomarkers. Finally, beyond imaging and structural biomarkers, we do expect and we do already know that there will be systemic blood, plasma, and genetic biomarkers for progression to geographic atrophy. Commonly known, these include C-reactive protein, which can confer an odds ratio of 3 times risk of late AMD. Having increased high-density lipoprotein cholesterol also increases your odds of developing late AMD, and that odds ratio is high in Asians compared to European populations. There has been an increasing interest in plasma metabolites, and in this study, they did identify the alanine glutamate metabolism cycle as well as the citrate cycle as being important metabolic pathways conferring risk of AMD progression to geographic atrophy. We also know there are many genetic markers, including the most well-known complement factor H, as well as the ARMS2 or HTRA1 gene loci. And there are various other complement factors that have been also polymorphisms, which have been also associated with progression to geographic atrophy. In conclusion, we are well aware of the traditional color fundus and fundus autofluorescence biomarkers for progression to geographic atrophy. Increasingly, it is believed the OCT biomarkers may be more important and sensitive in terms of identifying progression to GA. The important OCT biomarkers include hyperreflective foci, calcific drusen or hyporeflective drusenoid core, the presence of subretinal drusenoid deposits, drusen volume and height on OCT. In addition, iRORA may be the greatest risk factor for progression to cirrhora, which is an important risk factor for progression to geographic atrophy. That conversion rate may be between 30 to 60% at 12 months. AI-based imaging biomarkers have great potential to improve our prediction and prognostication of geographic atrophy, but much more external validation is required for these algorithms. More research is also required into the significance of systemic and genetic biomarkers, as well as how we can apply them to risk profiling our patients. All these biomarkers will be critical in order to identify which patients are at the highest risk of progression to GA and which patients would benefit the most from the newly available intravitreal therapies for geographic atrophy. And with that, I thank you very much, and we look forward to further research from all those involved in this field to better understand biomarkers for progression of geographic atrophy. Thank you.
Yeah, thank you, sir, for the wonderful presentation. So now I will call upon the panelists for this session. So Dr. Mahesh Shanmugam is the head of Vitreoretina and Ocular Oncology Services, Sankara Eye Hospital, Bangalore. So, and next, Dr. Lalit Verma is the president of All India Ophthalmological Society and director of Vitreoretinal Services at Center for Sight, New Delhi. And next, Dr. Girish Rao is the president and senior consultant in Sankarnetralaya, Chennai. And Dr. Pradeep Suswar is a senior consultant in Sankarnetralaya, Chennai. So, to start the panel discussion, I have a question for the panel. So, is there any way or technique to measure the volume of the atrophic area in case of geographical atrophy? Usually, we saw the two-dimensional thing, but is there any three-dimensional measurement to take for atrophy in geographical atrophy?
You see, by and large, I think we do autofluorescence in most of these patients and do only two-dimensional. Although literature tells us that, volume studies also are available, but practically we are not doing in our day-to-day practice.
Orko, I have a question. Can I ask?
Please, please.
I have a question for Dr. Vas. Dr. Vas is there?
No, Dr. Vas would be coming tomorrow. He's actually traveling to China. So he has told that he will join first. But you can ask Dr. Gavin this question, but anyway, you can ask him tomorrow in the session.
So I have a question regarding the imaging. So as Dr. Sada said that with the advent of this confocal imaging modalities, we are able to appreciate the areas of atrophy better. So now, when the spectralis came up with this multicolor, we really only had flash photography. But now, most of the platforms like Edeon, Optos, California, Claris, all have really come up with something which is known as true color photography, which gives good contrast and almost and the advantage of confocal, and gives a wide view, which spectralis multicolor does not give. So in that Vas's paper, we have seen that multicolor was really useful in measuring the area of atrophy. But with the advent of these wide-angle true color imaging platforms, does it have a role? That was my question.
Rupa, would you still stress on this multicolor imaging modality or autofluorescence in diagnosis?
Yeah, so sir, that what my question is now with this Medante, Claris, Edeon, they have all have come up with this confocal true color wide angle photographs, which are beautiful and really beautifully demonstrates the geographical atrophy, because previously we had only flash photography with Zeiss and everything, where as the margins
Flash I think is out. I don't think so. Flash
yes, exactly.
has any place in diagnosis of geographic atrophy.
Yes.
The contrast which FAF gives, that is the best.
Dr. Dinesh,
yeah, I wanted to. May I?
Yeah, you are audible, sir.
Yeah, so I wanted to ask. Actually, everyone been talking about autofluorescence and various forms of color imaging, I have found that infrared reflectance imaging is probably the most sensitive way to pick up what's happening at the RPE level. So you can pick up the earliest changes in the RPE even more better than by doing an autofluorescence. Sometimes autofluorescence won't pick it up. You'll pick up earliest changes on infrared imaging. So any comments on that from anybody?
Yeah, I think that is an excellent point. Infrared imaging is really wonderful to pick up very early images, especially the Spectralis module has that infrared. Even in subtle diseases like AMN, where you are not able to pick up anything autofluorescence, the infrared can pick up that butterfly shaped hyperfluorescent hyporeflectance area. As sir correctly said, this is the reflectance imaging that is we are talking about.
Yeah, so
Yeah.
I agree because I think infrared, because of deeper penetration, I think is very, very sensitive to pick up this.
In fact, in the Spectralis, when you're doing an OCT, the image that you get is
Yeah.
actually infrared image, and you can get a beautiful idea of what's happening at the RPE level by looking at that image along with your OCT. So you can actually do a composite effect. So I wanted to know from Dr. Sada whether they've investigated that and done any kind of comparisons on that, but he's not there apparently. Dr. Gavin would like to comment on that.
Yeah, I think that the problem is we need to then go back to what we would define as gold standard, and that's a little bit challenging. I did see one paper that actually found multicolor might be a little bit better than near infrared. But all these colors, all these papers, the problem is they're always very, very small sample size. And again, depending on what they used as gold standard, I think that study actually used presence of Cirrora and Aurora as gold standard. So I think we can agree that a standard flash color fundus is something if you really, really thrown out, and you should be using one of these alternative modalities, whether it's multicolor or near infrared. But I think the jury is out, which is actually going to be better.
Yeah, another point is actually what happens is when you do multicolor, you merge the three different colors, the blue, the green, and the infrared, and actually you don't get as clear a view of the infrared of the RPE level that as compared to what you would get with only RPE. That means the infrared. So that's the other point. One more point I wanted to discuss, and Dr. Gavin, maybe you can comment on that. See, we keep talking about area of hypofluorescence on autofluorescence or area of increased reflectivity in terms of Cirrora and Aurora. The point is, these are not absolute terms. Actually, what happens is that the intensity of the hypofluorescence or of the hyper reflectivity will increase as the atrophy becomes more. So maybe the intensity of these changes, the intensity, in fact, I do that routinely in my clinical practice. You can see how as the patients deteriorate, the intensity of the hypofluorescence on autofluorescence increases. It becomes darker and darker. So in fact, a lighter image, an image showing a lighter lesion, patient will have better vision. It becomes darker, his vision also drops. So it's not just the size, it's also the intensity of the hypofluorescence which is important, which has not been mentioned anywhere.
Yeah, everywhere it is a 250 micron, which is stressed the area rather than the intensity.
Yeah, but I think that is
the problem that we have with intensity is if you take a picture, my technician takes a picture, I take three people with different severity of cataract. There's going to be there's difficulty in having a standardized definition that everybody can use. I think nobody's going to argue that you are not correct in terms of you do see changes in the autofluorescence or your multicolor intensity that changes. And in a way, it's kind of described in the patterns that in the Holtz paper where there are certain patterns where really it's a dense area where there's absolutely no autofluorescence, whereas others there's patchy kind of changes. So that's recognized, but I think it's going to be very challenging until we have better methods of quantifying it to make that a standard. So that's why I think it's not been used.
One suggestion for quantifying would be to pick up the normal retina adjacent to the area of choroidal atrophy, use that as your standard for each machine. So there the reflectance is now fixed for that machine. and do the ratio with the area of geographic atrophy. So the more hypofluorescent it becomes, the deeper the more the atrophy which is there. So actually you can quantify the atrophy if you do the ratio of an area adjacent with the area which is involved. In fact, you can create, just like we create for macular edema, a complete pattern of different degrees of intensity. We may be able to do the same thing for the atrophic areas also.
Thank you, sir.
Yeah.
Dr. Mike,
Yeah,
sir,
Dr.
wanted to ask or add comments.
Yeah, yeah, correct. Thank you. Thank you, Dr. Gavin, for a great lecture. Of course, Dr. Srinivas is not there. The interventions for geographic atrophy at the present moment have been yielding very modest results, and probably that's because we have started treating them once the atrophy occurs. We are trying to prevent it from increasing. It would have been better if in case we are able to define which patients with intermediate AMD are going to become wet AMD versus dry AMD. Of course, like the choroidal thickness may be one of the biomarkers. Can you tell us about if there are any biomarkers which will tell us at the stage of intermediate AMD, a particular patient is going to become wet AMD or dry AMD, and if it's going to be rather a geographic atrophy. So if you start treating patients at that particular stage, the outcomes may be much better. So are there any biomarkers which will tell us which patient is likely to go in for a geographic atrophy or to develop a CNVM?
Yeah.
I think the OCT biomarkers that I described earlier, where they were talking about hyperreflective lesions above the drusen or the calcific drusen, those are biomarkers that are more likely to convert to a geographic atrophy. But again, although I do agree earlier treatment may yield better results, the question then becomes, this disease is not uniformly progressing in every patient. And I think if you treat too early, conversely, in a 1-year clinical trial, you may not find that you yield any result as well because your control group might not progress fast enough. Yeah, I don't know whether Alexandra is here and she wants to comment a little bit on this, on in terms of how we might be better able to identify the best candidates for treatment. Or I don't know if she's going to cover that in her talk later.
Yeah, Dr. Alexandra and Dr. Barak. Yeah. So good evening. So welcome here. So any comments for this session, please?
Well, I think, thank you so much. I think we're going to see some of these covered in the next section as well. And I think it's really an important topic of discussion, trying to figure out which patients might be best suited for these treatments.
Okay, so yeah, thank you for the wonderful discussion. So for the next session, I will call upon Dr. Rajiv Raman, Senior Consultant, Sankar Netralaya, Chennai.
Thank you, Akka. So we move to the last session of today, and I would invite Dr. Alexandra.
So when we look at these two drugs, it's important to remember that given the way the studies were designed, and both the design, the inclusion-exclusion criteria, and such, it's really hard to compare these two drugs directly to each other. We continue to learn about them and continue to see how they can be used in our clinical practice. So in conclusion, GA, in my opinion, is still, excuse me, an under-recognized condition. Multimodal imaging is paramount in GA diagnosis and early detection because potentially patients who would benefit the most are the ones who don't have extremely advanced disease. And there are currently 2 approved therapeutics in US, pegcetacoplan and avansicaptad pegol. And we look forward to learning more about these medications as well as the other therapeutics that are making their way through clinical trials. I appreciate your attention, and please don't hesitate to contact me. Thank you so much.
Thank you, Dr. Alexandra. We'll take the questions at the end of this session. I'd like to welcome Professor Barack Cooperman, who is Professor and Chair, UCL Department of Ophthalmology and Director of the Gavin Herbert Eye Institute. Welcome, Professor. And before you start your talk, would like to, he will play directly his talk. So you can just off it.
You can use this talk. You can, if you want to just run that one, that's fine too, Rajiv, whatever you prefer.
No, I would like, before we start the talk, we were discussing about imaging. I would like to know your preferred mode of imaging in geographic atrophy.
Well, I think as Alexandra mentioned, we're turning more and more to autofluorescence. That seems to be the most useful tool. Of course, I haven't been consistently getting autofluorescence over time, and we're looking forward to software that can help us analyze these patients better, because in the hopes that we're going to show some slowing down, it's probably good for all of us, especially you that don't have access yet, to start getting some baseline photographs of autofluorescence, because there is some software emerging and some AI that can be used to do with only, there's some talks that have been given that with just 2 or 3 samples, you can start plotting curves of rates of growth. And then you could hopefully then, after you start initiating injections, you can also, after 2 or 3 visits, plot a new rate of growth to see if there's a change. The reason to do that, in my mind, is that we don't have any control over it. It is what it is. But it's nice, when we show the OCT to our patients with wet AMD, we can show them a benefit. They see the OCT and it looks dry or it looks wet. Now we have nothing to show them really over the short time. But if we could show them even a plot which shows the rate of growth is diminished because we have initiated therapy, even by a modest amount, I think psychologically that'll be a good factor to have. Alexander gave a great presentation. One of the things, though, is the dropout rate in these studies. Even in these studies with highly motivated patients that are in clinical trials, about 20% or so dropped out. And the number one reason for dropout was a lack of perceived benefit by the patient, fatigue of the process. So this is a new patient category with a new patient treatment that we're going to have some mechanism of encouraging their adherence to the program. So having autofluorescence and having the software, which isn't commercially available yet, but hopefully will be, that can show the rates of growth over time and showing the change in that slope, as Alexander showed in the study, that I think will be very beneficial to help our patients maintain adherence.
Thank you, Barry. Shall we play your presentation, or would you like to directly give? That would also be fine.
I mean, I think I'm happy to have you play it, or I can give it whatever you prefer. It doesn't matter to me.
Sure. Viraj, can you play the presentation?
Hello, it's my pleasure to give this talk on reversing vision loss in dry age-related macular degeneration. We'll be focusing on matching the mechanism with the right patient population and stage of disease for studies in dry age-related macular degeneration. And within this talk, I'll be focusing on 2 new drugs under development that meet this criteria. Again, it's my pleasure to be here. I'm Barry Cooperman from the Gavin Herbert Eye Institute at the University of California, Irvine. These are my financial disclosures, and I will be discussing in particular 2 drugs under development. One is by Allegro Ophthalmics, and the other is by Stealth Therapeutics, and you can see that I've listed myself here as a consultant to both companies. By way of background, dry age-related macular degeneration remains a highly unmet medical need. Again, now we have 2 drugs available in the United States for geographic atrophy, and they slow down the progression of the lesion. So we're grateful for that. But they've not shown a benefit in vision, at least in the overall population, maybe in some subsets. There's still more work to be done, even though we're grateful to have these 2 products. We also know that intermediate dry macular degeneration makes up about 40% of the dry AMD population, again, prior to getting to geographic atrophy, and geographic atrophy only makes up about 10% of the dry AMD population. So these 2 new assets, these 2 new drugs that are under development, are in the early phase of development, have shown promising results in reversing vision loss. Again, this is important, not slowing down the rate of worsening, but in fact, reversing vision loss in dry age-related macular degeneration. And interestingly, they both target mitochondrial stabilization. These 2 products are rizutigimod, which is proprietary to Allegro Pharmaceuticals, and elamipretide, which is proprietary to Stealth Therapeutics. Both drugs have shown threshold OCT characteristics that predict the vision response to treatment, so we can enrich the target population. And there's even better news, as I'll get to at the end of it, that we can also potentially use anatomic endpoints even as a design of clinical trials, even beyond enriching the population with the ones that are most likely to respond to treatment. So again, further background, epidemiology of dry age-related macular degeneration in the United States. Just to clarify this, again, interestingly, if you look on the right, something between 32 and 41% of eyes with early or intermediate age-related macular degeneration have already suffered a vision loss to 20/40 or worse. One could argue that they require intervention. If you look at the pie chart on the left, you can see that fully 42% of the population with dry AMD has intermediate disease. If you look at the geographic atrophy subgroups, foveal involvement in green and no foveal involvement in purple, they comprise about 10% of the population, those two wedges to the left. So we do also know that age-related macular degeneration is characterized by marked mitochondrial defects. A variety of things happen, including extensive loss of cristae and matrix density and those mitochondria. And while I'll be discussing both products, I'll be focusing initially on rizutigimig. So I just want to mention that lamepirtide stabilizes the cristae architecture and electron transport chain structure during oxidative stress by binding to cardiolipin, but I'll get in the inner mitochondrial membrane, but I'll get to that in more detail later. Further data has shown that progressive mitochondrial dysfunction contributes to age-related macular degeneration. You can see here changes in RPE mitochondrial properties in age versus AMD eyes. You can see that the RPE mitochondrial and AMD eyes undergo more pronounced degenerative changes with lower mitochondrial density, smaller organelle area, and smaller cristae number. So lamepirtide, which I'll get to in the, later, but I just want to first mention it briefly before I focus on rizutigimig, stabilizes the cristae architecture. So that's what it's doing by binding to cardiolipin, and this is a sort of picture of what it looks like. It restores the cristae networks. But I'm going to transition now to talking about rizutigimig and focus on that for a bit, but I'll conclude with talking more about lamepirtide. Rizutigimig preserves mitochondrial structure in RP cells under stress. There's a lot of preclinical work. Much of it has been done by Glenn Jaffe at Duke. You can see here in these in vitro studies. And again, our lab at UC Irvine, my lab, has also corroborated some of this work. And particularly this here, Glenn has shown that our rizutigimig improves mitochondrial structure and restores energy production in these in vitro studies, as well as it improves survival of cells stressed by cigarette toxin, hydroquinone. And again, we've also looked at this in our lab and have found a similar result. Again, there's ample evidence that rizutigimig has an impact on preserving mitochondrial function. So a study was done, phase 2A study, that was unusual in its study design. It was randomized double masked 40 patients, but there were two arms. One was a sham control arm that had 15 patients. The other was a rizutigimig arm in blue, and it was slightly asymmetric in the sense that rizutigimig was treated at baseline, sham was observed at baseline, and then at 16 weeks, the rizutigimig arm received a second injection, and the sham arm became a crossover arm, and it received its first dose of rizutigimig. So the study endpoint, what was compared was at 28 weeks in the rizutigimig arm in blue versus at 12 weeks in the sham arm. Now, that seems asymmetric and confusing, and I admittedly, but the sham arm, we know that disease gets worse over time, not better. So the thought is to look at it at a smaller interval to minimize any likelihood of worsening in the sham arm, and looking to see if there was any benefit from the rizutigimig arm. And again, the primary efficacy endpoint was percentage of eyes with 8-letter improvement. And what the study showed that, in fact, if you looked at the primary endpoint of 8-letter or more improvement, 12 out of 25 eyes in the rizutigimig treated group showed an 8-letter improvement, 48%, amazing. One eye in the sham control managed to gain 8 letters. In fact, that eye gained 10 letters. You can see in the middle columns, middle bars, that again, 7.1%, 1 out of 14 gained 10 letters. At this point now, 8 out of the 25 had gained, treated with rizutigimig, had gained 10 letters. And in fact, if you look at the far right, no sham eyes gained 15 letters, the incredible high standard, high bar to be set that the FDA has wanted in the past, and we was able to achieve here. In 20% of eyes, 5 out of 25 eyes did in fact gain 15 letters or more in this period of time. It's also worth noting that the rizutigimig best corrected visual acuity responders also had improvements in microperimetry and color vision. In fact, here's a subject with microperimetry. You can see the characteristics on OCT, and you can see their microperimetry improvement by looking at both above and below. So what were the predictors of response to rizutigimab? Age, gender, race, genotype did not correlate with response or lack of response to rizutigimab. However, the OCT criteria at baseline did correlate with the best corrected visual acuity response to rizutigimab, and I'll go into some detail now. This has been looked at by Justice Ehlers at Cleveland Clinic and Glenn Jaffe at Duke. They've used their own mechanism for doing it, but they're looking at OCD biomarkers for rizutigimab response using automated OCT segmentation and feature extraction tool, essentially looking on FOSS to make out details of all layers, including all the ILM, ONL, ELM, EZRP, and Brooks membrane. And what they showed is predictors of response, that is BCVA improvement to rizutigimab, for those eyes with enhanced ellipsoid zone integrity, greater outer retinal thickness, and decreased geographic atrophy. And here's some examples of a rizutigimab responder. You can see the OCT, classic OCT-B on the left above with the drusen, et cetera, but no obvious or minimal GA. You can perhaps see a little bit of GA there. And below, you can see what the on-FOSS map looks like compared to the right with clear areas of GA, both above and below, and that was a non-responder. Again, a post-hoc analysis that was done by both Duke and Cleveland Clinic Coli Center. And again, looking at the responders defined in this study as patients with 8 letters gain, you can see a normal OCT scan on the left, a responder in the middle, and a non-responder on the right. Both reading centers independently concluded that more preserved the photoreceptors, the better response to rizutigimab. Therefore, those eyes with a 30-micron photoreceptor layer, that is EZ plus RPE, the photoreceptor layer will increase the responder rate by 40%. So we've identified a population more likely to have a benefit from this, and this is the population we'd like to enroll in future studies as an enriched population that are more likely to be able to gain vision with treatments of this type. So now let's switch gears and talk about the other product. Again, as I've mentioned already a couple of times, elameprotide. I've mentioned that cardiolipin, that we know is essential for mitochondrial function, and altered cardiolipin metabolism is associated with a range of mitochondrial disorders. And elameprotide binds to cardiolipin to restore mitochondrial structure and function. This is throughout the body, and in fact, this is a drug that's given systemically, subcutaneously. And so in the initial study, the RECLAIM-1 study, there were 2 populations, those with high-risk drusen and those with non-central GA, and they were given elameprotide subcutaneously once daily. The patients do that themselves. And the primary efficacy endpoint for that study was safety, but again, they looked at a variety of secondary endpoints, including low luminance visual acuity, best corrected visual acuity, and others, as you can see here. And what was shown is that predictors of response in the post-hoc analysis of the phase 1 RECLAIM study in the high-risk drusen group, mean central thickness positively correlated with improvement in low luminance BCVA, and eyes gaining 2 or more lines had significantly greater baseline preservation of the central macular outer retinal layers. Again, in this baseline, higher order OCT parameters, such as EZ integrity, were correlated with function response and improved low luminance BCVA in eyes treated with subcutaneous elameprotide, somewhat comparable to what we saw with rizutigimab. And in fact, this informed then the RECLAIM-2 study. And again, this was looking at non-central geographic atrophy, 117 eyes in the elameprotide group, 59 eyes in the placebo group, followed for 48 weeks. Again, daily subcutaneous elameprotide in the treatment group. And what did they see? In the categorical 2-line gainers, you can see the shift to the right. You look at those eyes, you look at in the box you look at visual acuity of elameprotide, and by category, how many lines of loss or gain, you can see there's a shift to the right compared to the placebo group. And in particular, in the box in blue, those that had 2 or 3 lines gain were significantly greater in the elameprotide group compared to the placebo group. Additionally, it showed that very importantly, it reduces EZ attenuation. And so this is a pre-specified analysis which provided proof of mechanism and elameprotide target engagement. We can show that elameprotide treatment reduces the progression of EZ attenuation. This is very important because the FDA has indicated they may be willing to accept this as an endpoint. So not only do we know that there's a patient population that may be enhanced outcomes because of their relative EZ preservation, but also we can follow that EZ layer over time as a potential acceptable surrogate endpoint for progression of disease rather than just simply showing improvement of vision, even though, of course, our goal is to improve vision. So in conclusion, restoration of functional vision seems achievable in dry AMD with more anatomic and patients with more anatomic integrity using mitochondrial stabilizing drugs such as rizutecanib or lamipretide. This suggests that early treatment of dry macular degeneration is warranted and for vision loss, and we can prevent vision loss. And in fact, we may be able to improve vision loss in patients. So this is very exciting, different than stopping or slowing down the progression of disease. We are actually being able to show that we can enhance visual function. In a clinical trial, when you're designing this, and this is important for other companies as well, it's important to establish thresholds such as minimal EZRP thickness to enrich the study population to have the potential to improve. So you want to look for patients that have some damage, but acceptable anatomic surrogate endpoint for clinical trials. This is still in discussion with the FDA, but they've indicated their openness, much as GA lesion size progression was an acceptable endpoint for the GA studies. The reduction of EZ attenuation may also be an acceptable endpoint. And so even though these drugs are capable of improving vision in a subset of patients, we may not even need to use that preferable or certainly laudable endpoint. We can use this anatomic endpoint as perhaps a more achievable endpoint for the development of these drugs. So it's an exciting time for this area in that there are new drugs under development and new pathways to both enrich the target population for clinical trial design and to have new endpoints for the treatment of these patients such that these drugs could reach it to the marketplace. I'd like to thank you all for your attention.
Thank you. Thank you, Professor, for such a nice talk. Before we start the discussion, I would like to invite the panel. We have in panel discussion Dr. Manisha Agrawal. She's a senior vitreoretinal surgeon at Dr. Shroff Charity Eye Hospital in Delhi. We have Dr. Dinesh Talwar, who is a senior vitreoretinal surgeon at Indraprastha Apollo Hospital, Delhi, and Dr. Subneshwari, who is a senior retinal surgeon at Shankanetralaya, Chennai. Before we start with the panelists, I have one question for both of you. Dr. Alexandra, we saw the two drugs and we know that they are now available in the US. Are you offering this treatment now? And how you decide which patient you should treat, and how is your experience till now?
Thank you. Thank you for the question, and thank you for the invitation to be here today. It's very interesting how the process goes from the drug approval by FDA to drug being available for us to use. And in US in particular, there's kind of two different passes. One applies to if you practice in a private practice environment, and another one is an academic environment. So for instance, at Coli, it takes us several months to get the drug on formulary, whereas if you practice in a private practice setting, it happens much faster. So when Syfovre was approved back in the early spring of this year, there was a lot of use that happened in private practice, whereas for an institution like Cleveland Clinic, it takes several months for the drug to get on formulary. And I think the story has changed as we've seen the reports that I've alluded to, both
we do have Syfovre, and probably in January I'm going to start something. But the protocol in my mind, how I'll approach it, is no longer look at the good eye. I'll say, well, the risk for occlusive
Gopal has a question. How many follow-up visits you need to establish progress or otherwise offer GA?
Patients either have fundus photos, and that might still
About that maybe after just 2 visits with AI, they can do calculations of the slope of progression and you have that math, but that's not really available. In my mind, essentially everybody's eligible for consideration. Then you have to take into account the safety profile. Is this their only eye? For example, right now, an only eye that was 20/40, I don't know, Alexander, would you start treating that eye? Let's say they have, when I say only eye, of course, I mean one eye is 2200 or worse, so central GA, obviously peripheral vision in the other eye. Now you've got a good eye, 20/40. Now that's it. Now, is that an eye that you would start treating? The answer for me is maybe yes, but I would certainly start the other eye. And what are you thinking, Alexandra?
Yeah, I think it's really changed, right? It's the discussion of which patients to treat and which eye to treat has really changed. The other, and I totally agree with your approach. I think that's kind of the approach these days. But as we learn more, we might change again.
All this is in flux. 100% agree with that.
Yeah. One thing I would mention is, for the new patient that you've seen for the first time, as opposed to neovascular AMD, obviously, you have time. This is not something you have to treat on that day. And as Barry mentioned, I've been talking to these patients when the studies were ongoing because that conversation needs to start. You don't want to start with the patient from the first day and go through the whole thing. I mean, they're not going to be able to retain all the nuances of what you're talking about. So I've been talking about GA and GA treatments, upcoming treatments, so it's easier as you build on each visit than when you're offering them treatment. You're like, as we've been talking, and then it's the continuation of that conversation. So I think majority of people wouldn't treat on the first visit, but start the conversation because we know we have time with these patients, luckily.
And on a related note, I know there's hands raised, but just to complete the other patient population that is coming, because I referenced two, there's the ones that we've been following, but there is an actual huge, that may be just the tip of the iceberg. There are a ton of patients that are in the hands of optometrists or comprehensive ophthalmologists that never bothered referring those patients because there was no therapy. And now that there is a therapy, they're beginning to refer them in. Now, most of those have been followed. So, and again, the optometrists, in particular in the United States, they love doing testing more than ophthalmologists and more than retina specialists. So many of them have had a long history of certainly OCTs and probably fundus photographs. So most of the new patients that are being referred into us have been already a series of imaging studies that we can have access to as well. But that's shows sort of the unmet need. There's a huge population that were not even in the retina specialists clinics because there's given this history of no treatment. But now that there is a treatment, they're being referred in a big way.
I think before we just start with the panel and the questions, I have one question for Dr. Gairing. You had this cardiolipin one, and we know that anti-cardiolipin antibodies are actually prothrombotic. So do you expect that these patients will have more thrombotic events, though it is given systemically? So,
right, of course. So this is the downside of this therapy, which is the very appealing results, shall we say, but subcutaneous injections daily. Now, Nobody loves that, though. Of course, in the United States, the drug du jour, everybody loves Ozempic and Mounjaro. That's subcutaneous injections weekly. So, but people see the benefit; they become slim and beautiful again. But they're not. So this is going to be a challenge for the company. But it's been used systemically for other conditions. It's been a drug that's been under development for some time, has been looked at in other conditions without this risk of thrombotic events. So we've not seen that in the various trials with this compound, but it's certainly something to maintain vigilance about. So it is it's interesting, but again, how this will be adapted. Can they extend the half-life? Can they do anything? I don't know. It's a little bit of a challenge to think about a daily subcutaneous injection.
Just one more question, like current management or present standard of care are the AREDS regime, the AREDS supplements for intermediate AMD without CNVM. So how you place AREDS comparison to the drugs, as to we really don't have much visual improvement, but progression of the disease definitely it reduces.
I don't know if you're asking me or Alexandra, but the AREDS, all my patients are still on AREDS, but don't forget its main effect is to decrease the likelihood of conversion to exudative, to choroidal neovascularization. There is some modest effect in progression of dry AMD, but its main effect is to decrease the rate of conversion to wet AMD. So I still think it's worth continuing my patients, and I encourage them on a healthy diet of fish 3 times a week for those that are non-vegetarians, and daily dark leafy green vegetables. I still recommend those as well.
Dr. Dinesh, please.
So actually, the first question is a tweak of what Dr. Lingam Gopal was asking. Actually, when you have a patient who's got dry AMD, say vision is 6/6, forget about 6/12. Now, what does your data say about how long does progression take? I mean, for you to be able to document that this is progressing fast enough for you to treat, how much time do you need to follow a patient? You said there is time. The question is, how much time do I give to my patient? I know lots of my patients who have not progressed. I mean, we're talking of progression, but I also know patients who have progressed, who have followed for years without further progression. So how would you decide which patient is progressing? And how long would you follow them up?
Alexandra?
Both of you can answer. I mean,
I've been talking too much. Back to you, Alexandra.
So I think it's an excellent question, and I don't think any of us have a clear answer. There's a lot of work trying to create this predictive algorithms, where you can put in multiple variables to determine if somebody is at risk of progression. There's some thought that systemic comorbidities relate to progression, and imaging biomarkers. If you have subretinal drusenoid deposits, if you have large volume drusen, if they have this, hyperreflective core, presence of iRora, all of that. But I don't think there's a way where you have a patient and you can enter all this and it will give you this beautiful result. And that's exactly the point. As we talk about the patients who might be slow progressors, and the drug that we have, the therapeutics we have now, which is fantastic to have something, they carry a risk, not only risk of injection, but other risks, conversion to neovascular AMD, ischemic optic neuropathy, elevated pressure. So I think it's ongoing learning. I think we're learning so much about geographic atrophy. If you think, like couple years back, geographic atrophy was the most boring session, right? You would go to an annual meeting and there would be like 3 people in the audience. And now there's standing room only for all these GA sessions. And we're learning so much. And then I think the other elephant in the room is, we all think about this GA progressing from neovascular AMD, but as we know, there's GA that's concurrent with macular neovascularization. And is it a different type of patient? Is there something different about that geographic atrophy? And, and then that goes into the patients who have complications, maybe they're the ones who were more previously treated with anti-VEGF. It's so complex that I think it's going to take us some time to figure it out. But as we've all been talking, as we figure it out, we also need to know what to tell our patients and take the best care of our patients.
And agree 100% with that. And as we're everything we're telling you today, forgive us if we change our mind 6 months from now and 12 months from now, because we're just doing the best we can with the emerging data. But for example, another thing we don't know and I don't know I don't know if we'll be able to tell from the studies, but are there subsets? Just so we saw, for example, the vision does not improve overall. There's a curve that slopes down. Also, those rates of GA growth seem to slow down and progressing more over time. But are there subsets? And are we going to be able to identify subsets, and what are their characteristics that benefit more from this treatment and others that benefit less? We have no idea yet. We're looking, and people like Alexandra and her colleagues at Cole are amongst the leaders in looking at this. We still don't know. So we're just beginning to learn about this field, and we're grateful for these products, but we're looking to see how we can make them how to apply them most effectively.
Dr. Cooper, then, you showed, both of you showed that the effects become better with time. So the longer you give the treatment, the better the results are likely to be. But does the incidence of neovascularization also increase with time?
Yes,
Well,
it does.
Alexandra, you go,
It does.
because there's evidence more from you. Yes.
Yeah, we do see that as well, and I think it's interesting actually. I was thinking on the prior question, when we think about our neovascular MD, right? We know that not all patients are the same, right? In their response to treatment, we have patients who you treat once and they're probably fine for whatever magic reason. And then there's these non-responders that you treat every 4 weeks and they still have fluid. And I think as we learn more about geographic atrophy, we're going to start, now it's this is GA and it's like this general diagnosis, but we're going to learn much more about subsets of patients. But yeah, you're exactly right. It seems like, and this is something we've seen with other studies, some of the phase 2 studies, they see that separation as time goes on. So there's some type of cumulative effect that we see in patients who are on treatment longer.
I agree with
going to end up from the.
Sorry, I was going to just add. There's just one I'd like to add, because remember that in the year 2 of the Gather 2, if you looked at the rates of conversion to wet AMD, there was not, in the every other month group, it was again not statistical difference because the numbers are too small, but nominally there was no difference between the sham group rate of conversion. Don't forget, these patients convert to wet AMD at about 3% per year or something. And in the treated group, it was about the same for the every other month. So I agree but I think it's again just highlighting that the data is still emerging. We don't really know. It's probable. First of all, there's a baseline rate of conversion to exudative AMD or macular neovascularization anyway in the GA patients. How much in addition that is unclear from these treatments. And over time, it's probable to increase, but we don't know. And the only good news is that it is possible to treat both the exudation and now, to add that, which of course adds cost and burden to our patients. But that is, with the fears we have about occlusive vasculitis and ischemic ophthalmopathy, that's almost a secondary concern, because at least we can manage that, even though it's a legitimate concern.
Do they behave the same? Do these CNV patients who develop after treatment for dry AMD, are they behaving any differently from the normal patient who sort of, as a treatment naive patient, comes to you and is treated? Like, are they more resistant to treatment? Are they easier to treat? I mean, any difference in that? That's one. And the second thing, what worries me is, am I going to go from the frying pan into the fire when these dry AMD patients become CNV patients, which will now need lifelong, maybe even more intensive treatment?
So I think unfortunately, we don't have an answer to that either. We're learning, at the last meetings at Retina Society, Charlie Wyckoff presented some of the data on the patients who converted. The issue is also how do clinicians approach it, right? So if the patient converts to neovascular MD, do they keep both drugs going? Do they, alternate it? What treatment approaches do they employ? Because there's no treat and extend for geographic atrophy, but potentially you could treat and extend for neovascular MD. What is the follow-up? I think there's two camps. A lot of people say, well, if you convert, I'm going to start treating you for neovascular MD and stop the GA drugs. But some people continue both. So the data is a little heterogeneous, and I think we don't know if the behavior of those neovascular MD patients is different than those who just convert, on their own before any GA drug introduction.
And I agree with all that, with the caveat that at least in the clinical trial, they looked at those patients, particularly Syfovre patients, and it looked like it was pretty mild exudation. So they looked like they would be relatively easy to control. But again, as we've learned, the trial patients are such a small subset compared to the real world. So whatever we know, we know that we don't know enough to make coherent comments about that. But your point is well taken. There's a scenario, God forbid, where there may be patients with bilateral GA and bilateral exudation, and now they're subject to 4 injections. What the heck? How are we going to manage that? We don't know.
Thanks. So, Dr. Manisha, is Dr. Manisha there? Any comments or any questions you have? Dr. Subneshwari, you want to add any comments?
I have one question actually. What is the current definition for a non-responder?
For geographic atrophy?
Yeah, for the treatment.
I don't think we have it. I don't think we have it because we don't have really good biomarkers or any functional tests to determine the responders. So I think it's something that is going to develop. I think in the questions there was a question about low luminance visual acuity, and other functional tests. It's the functional part of geographic atrophy is extremely tricky because we know that best-corrected visual acuity and low luminance in the clinical trials of the 2 therapeutics that are approved, there was no difference. There was some discussion of preservation of 15 letters or more difference, and initially it seemed like in the Iserway studies there was that separation, but then by 2 years there was no difference. Microperimetry is kind of interesting and promising, but microperimetry was only studied in oaks, so it's a small population. It wasn't studied in Avancicaptad-Pegol studies. So once again, we're learning, and microperimetry is not an easy test. It's not an easy test to administer, and it's not an easy test to do for the patients with geographic atrophy. So I'm curious as we struggle with that anatomic outcomes and functional outcomes as new drugs come about, the ones that Barry talked about. What are we actually going to be looking for as outcomes? And the other interesting thing, if you think about it, is as these new drugs come about, what's going to be the comparator now? Is one of these drugs going to be a comparator because they're an approved therapeutic? It's truly kind of a fascinating time to practice, and there's a lot of hope, I think, and it is exciting.
Yeah, I agree, Alexandra. So back to your question, in the IROR, CROR, the earlier treatment group, again, as I pointed out, looking at ellipsoid zone attenuation or the overall thickness has been looked at in several studies. And I didn't mention there's yet another treatment from a company called J-Site that has retinal progenitor cells. They're looking at retinitis pigmentosa, but they're using, again, a similar analysis by Justice Ehlers from Kroll that if you, and Sunil Srivastawa, that if you look at that EZ zone, in some of these earlier cases, those are predictors of responders. But once you get to frank GA, we don't have that, as Alexander pointed out. So when I was referring to that enriched population, those patients more likely to benefit, that's still in clinical trial for earlier development things. We don't know which are going to be the better responders within the GA category. We're going to try to learn that over time. And again, as Alexander pointed out, microperimetry, but that's a pain. Low luminance, nobody really does that in real life. That's a clinical. That's only in clinical trials do we bother with those things. So we're still struggling. We're still flying at 30,000 feet and trying to get down and learn more. And then finally, there's a question about myopia-related atrophy in the macular area, whether the GA drugs could be considered for that. And I think the answer, it's not on label in the United States. We practice a bit differently because even our private practices are all paid for by insurance companies. So we have to follow the label. The insurance companies won't reimburse for these drugs that are hideously expensive. America subsidizes the rest of the world we pay very high prices for drugs so that the rest of the world can pay less high prices. Not that it's cheap everywhere else, but it's less expensive. So we tend to follow the package insert and the label indication. So I'm sure that there will be some people that will use it for macular atrophy related to myopia, and it might very well work there. We just don't know. There's no data at this point. I know, and by the way, as a final piece, why that one weird case of Izervay with occlusive vasculitis was given in a Stargardt's patient. Iveric Bio did do a study and started a study looking at Stargardt. So and that's why this doctor thought that he would use it for this. But they are thinking about other sorts of indications. But for now, all the focus is on geographic atrophy.
Thank you very much. It was really a great discussion, a great learning. And I think one of the comments Dr. Parveen rightly said, let's continue learning. Let's keep learning. And so it was a nice session. We learned a lot, though we see in Asians less geographic atrophy, but we have seen that in India and Nepal, the prevalence of geographic atrophy seems to be a bit higher. We also know that we have now 2 FDA approved drugs. We are looking at probably this center involving, we'll have now not only DME, but center involving and non-center involving GA, and probably preventing it is something. And a very exciting newer drugs for intermediate AMD, which is more common as compared to geographic atrophy. And I'm sure next couple of years would be very exciting as far as age-related atrophy is concerned. I'd like to thank all the panelists, all the speakers, and I would request you to join tomorrow for the next session, which is on atrophy in some other diseases like rhematogenous detachment, diabetic retinopathy, retinal vein occlusion. That would be interesting talks too. Thank you very much. I would like to thank, we have a small video for people who helped us do this atrophy symposium. We'll just have that. Thank you.
Thanks for the invitation. It was great seeing you all. Great presentation, Alexandra. Enjoyed it.
Good to see everybody. Take care.
Bye.
Bye-bye.
Bye.
Accentrix is now available in a pre-filled syringe. This pre-filled syringe can be prepared in 4 easy steps. Using the Accentrix pre-filled syringe offers the potential to save time and reduce the risk of contamination. Here is how it works in 4 easy steps. 1. Release the syringe from its pack. 2. Snap off the protective syringe cap. 3. Attach the injection needle of your choice. And 4. Set the dose. First, hold the syringe upright and check the air bubbles. Then gently tap the syringe with your finger until the bubbles rise till the top. Expel the air bubbles along with the excess solution by carefully pushing the plunger until the edge below the dome of the rubber stopper is aligned with the black dose mark on the syringe. This sets the dose at 0.05 ml. That's it. The Accentrix pre-filled syringe is ready to use in 4 easy steps. Release, snap, attach and set. The Accentrix pre-filled syringe offers the potential to save time and reduce the risk of contamination. Accentrix, designed to save sight.
The paradigm has shifted. Innovation has arrived. Vabysmo is the first approved bispecific molecule, uniquely engineered to target VEGF-A and Ang2 to restore vascular stability, with a modified FC region to reduce systemic exposure and inflammatory potential. Discover the new possibilities of dual pathway inhibition. Vabysmo, where 2 worlds meet.